I would be starting with the IC. I would like to introduce my co-instructors for the IC. I'm Dr. Manish BAPAYE. I'm from Nasik, Maharashtra. Dr. Pramod Bhende sir, our guru, head of vitreoretinal department, Shankar Netralaya, Chennai. Sir will be presenting on sutured SFIOL. Dr. Sunil will be talking about glued IOL. He is from Davangere, Karnataka. Dr. Manavi Sindal from Arvindaya Hospital, Pondicherry, will be speaking on Gabor Shariat technique. Dr. Nivian from Chennai. Dr. Nivian, can you please come on, guys? Dr. Nivian from Chennai will be talking about his patented innovation CMT Flex IOL, which is becoming very popular now. Dr. Aditya Kelkar from NIO Pune will be talking about Kanabrava technique, which is a newer technique. And Dr. Mandar Zogolekar, who does Yamane technique extremely well, he will be speaking on that. He's from Kolhapur. I'll be starting my presentation. It is about IOL power calculation in scleral fixated IOL. So SFIL is a popular method of treatment of aphakia, and various techniques are available, and newer techniques are being introduced on continuous basis, and many have already been introduced. The surgeons have a large variety of techniques to choose from, and safety and favorable outcomes of all the techniques have been well documented. However, the literature on refractive outcomes is lacking. So there are only 4 papers in English language and 5 total on PubMed search in last 5 years. IOL power calculations are typically carried out for placement of IOL in the capsular bag when we are doing it for cataract surgery using optical biometers. And we VR surgeons tend to assume that the lens will be placed in the same place, whereas in the back position inside the eye. However, we need to look at our data of residual refraction to fine-tune our refractive outcomes. These are various parameters which are used by IOL power formulae for calculating the IOL power, like net corneal power, axial length, anterior chamber depth, lens thickness, white to white, CCT, a constant of IOL, and post-operative target refraction. However, in aphakic patient, ACD cannot be determined accurately, and post-op refraction depends on IOL position inside the eye, which can be variable in SFIOL depending on where you are going to implant the IOL. So we decided to look at our data from our hospital, and what we saw, we included patients who had undergone scleral fixated IOL from 1st January 2022 to 31st of December 2022. I have done, all surgeries were done by me, and glued IOL using Alcon 3-piece IOL was done. IOL implantation was done 1.5 millimeter posterior to the limbus. Pre-operatively, optical biometry was done using IOL Master 700, and IOL calculation formula used was Barrett Universal 2. The patients who had follow-up more than 3 months were included. There were 44 patients which were identified. However, only 32 could be included as they were filling the inclusion criteria. So there were patients, there were 32 eyes. Out of that, 9 had surgical aphakia. There were patients who had dislocated crystalline lenses or subluxated were 7. Those patients who had dislocated or subluxated IOLs were 10. There were 4 traumatic cataracts. All 4 patients, these were the only 4 patients who had trauma. There were no other patients of trauma in the whole group, and there was a patient of microspherophakia who had undergone surgery in both eyes. So coming to results, the mean spherical equivalent at 1 month was 0.46 with the standard deviation of 1.46 diopters. Median was 0. Mean spherical equivalent at 3 months was 0.23 with standard deviation of 0.9. And a spherical equivalent reduction between 1 to 3 months was not statistically significant. The mean BCVA at 1 month was equivalent to 6/15 Snellen's vision, and at 3 months was 6/10 Snellen's vision. about 30% of the eyes had a spherical equivalent of more than 1 diopter plus or minus, and BCVA improvement from 1 to 3 months was statistically significant, suggesting that with the glued IOL technique, it takes more than 1 month for visual stabilization. Even though the refraction may be stable by 1 month, the vision can still improve. This should help us counsel the patient about delayed visual recovery, and we can tell the patient that there will be improvement as the time passes. Patients with trauma had a higher spherical equivalent by 0.3 diopters, minus 0.3. So that it kind of shows that it might be more difficult to do optical biometry in traumatized eyes. So when we reviewed the literature, as I said, there were only 4 papers in English in last 5 years. The first was by AIOC2023 et al. In 2021 publication, they had done 14 patients where transconjunctival trocar-assisted 3-piece IOL was implanted 2 millimeters posterior to the limbus. SRK-T formula was used for 22 to 26 millimeters eyes, and Haigis for more than 26 millimeters. And they ended up with, the target was emetropia, however, they ended up with hypermetropic shift. Orr et al., who did 20 cases in literature published in 2020, they did Bausch & Lomb lens, which was fixated with Gore-Tex suture 3 millimeter posterior to the limbus. They used SRK-T formula and had predicted refraction of minus 1.12, while they achieved minus 0.96, and there was some hyperopic shift as compared to the desired refraction, but SRK-T formula was found to be effective in their studies. This was the third study is a very interesting study by Lee Z et al. In 2021, where they studied SFIOL in pediatric population, where they used Rayner lenses and sutured it with tenoproline suture 2 millimeters posterior to the limbus, and they looked at effectivity of the 5 formulas, that is SRK-T, Holliday, Hoffer-Q, Haigis, and Barrett Universal 2, and they found that SRK-T had a best choice, and there was a myopic shift in these pediatric patients. While Botsford, who had published in Retina in 2019, they used Acryos lens again using Gore-Tex, and Alcon lens this is a lens which has eyelets in the haptics. So that IOL was used using Gore-Tex suture 3 millimeter posterior to the limbus, and they also looked at the effectivity of all the formulae. And what they found was that there was myopic shift in their cases, and there was underperformance of Haigis formula, while all other formulas worked fairly well. So Dr. Warren Hill in this online publication has suggested we can make these changes when we want to shift the position of the lens. Depending on the position of the lens, we can change the IOL power, reduce it. And so to conclude, I think when we are doing SFIOLs, very often we are concentrating on technique and doing it right. However, the refraction is not on top of our minds as VR surgeons, but the patient satisfaction depends on uncorrected post-op refraction. So we have to look at IOL power calculation more in depth, and surgeon needs to optimize their results, because there are so many techniques, there are so many types of IOLs which are being used. If you are comfortable with 1 or 2 techniques, one needs to kind of look at their results, post-operative results, and optimize the results for particular technique. And distance of IOL implantation from limbus appears to be a very important factor, because that determines the position of IOL inside the eye. I would like to acknowledge Dr. Sunny Sen Gupta from Mumbai, who helped me in analyzing the data. Thank you very much for your kind attention.